like to introduce Dr. Jörg Dietrich. He is an associate professor of neurology at the Harvard Medical School and director of the Cancer and Neurotoxicity Clinic and Brain Repair Research Program at Massachusetts General Hospital Cancer Center. And he's worked in the field of brain injury and neurological complications from cancer therapy for quite some time, 15 plus years, both in basic and clinical research. And so he's going to provide us, as a practicing neuro-oncologist, a clinical perspective on everything we've heard thus far this morning. Thank you, Dr. Dietrich.
Well, thank you very much for allowing me to participate in this phenomenal symposium today. And I would like to specifically thank the organizers, Dr. Taylor, Dr. Hervey Champer, and Jamora for inviting me to give my perspective in this particular session on mechanisms. It's always hard to follow a talk from Dr. Monge with all the exciting basic science work that is ongoing right now. And so I thought my viewpoint could be slightly different by taking the role of a clinician to see what are typical scenarios that are encountered in clinical practice. As Dr. Taylor mentioned, we do have at Mass General a specialized clinic for patients with complications that occur in the context of cancer therapy. And so as such, we do see a number of patients with very different scenarios, many long-term survivors who do not have active tumor-related issues, but do have active issues such as with cognitive impairment. And so I thought I would give kind of some highlights of this everyday scenario and focus with that on existing mechanisms that we see from both the clinical side and that do mirror some of the findings that have been obtained from basic science research. Okay. My disclosures, briefly, none of which are relevant for this presentation. And so I would like to start with a classic scenario of a case of a patient I have been taking care of. She's now a 59-year-old female who was previously a very highly functioning attorney, but diagnosed approximately 20 years ago with a left temporal anaplastic astrocytoma. In retrospect, we do know that this tumor was or is IDH mutant. She had seizures as her first symptoms and onset of the disease, and then underwent a subtotal resection followed by adjuvant radiation and 12 cycles of the alkylating methylating agent temozolomide. Also at that time was offered tamoxifen and Celebrex as part of a clinical trial. And fortunately, she was declared indeed a long-term survivor without disease recurrence for many years and has been under surveillance. The interval history, however, identified a number of ongoing challenges, not only focal seizures that continue to be an issue. So she was maintained on anti-epileptic medications with levetiracetam. She did have also, since diagnosis and surgery, a partial right-sided field deficit. But important for this session and symposium today, she developed progressive cognitive issues and had to quit working in her profession just a few years after her diagnosis. Issues became a little bit more complicated with her management after she developed TIA-like symptoms. In 2012, had to be started on antithrombotic therapy, but then subsequent additional strokes in 2017 and 2019 in various regions that were either part of the radiation field or not. And so on exam in 2019, she, even with the somewhat non-sensitive mini-mental score, she had a rate and score of 22 out of 30 points, as such qualified for a mild dementia, in particular with impaired attention, concentration, and memory deficits. As you have heard, she continued to have her visual field deficit. She was slurred and dysarthric in her speech, had mild dysphagia from her stroke-related symptoms of the brainstem, and also had right hemiparesis and was off balance and dependent on using a cane. You see here her MRI at that time point in 2019. And in the upper panel, you get an appreciation of the extensive deficit in her left temporal and parietal region with encephalomalacia and also white matter injury that was more pronounced on the left hemisphere compared to the right. In the lower or middle panel, you see the gradient echo, which identifies numerous microbleeds, small injuries to blood vessels that have perhaps been an issue as well in her onset. And then at the very lower panel, the most acute area of restricted diffusion. So in summary, encephalomalacia, white matter disease, brain volume loss, microhemorrhages, and cerebral infarction. This case is another exciting case for this session because it illustrates issues that have come up in low-grade glioma patients, which is here a patient with a optic pathway glioma that was treated 17 years prior with combined radiation and chemotherapy. And then on the image you see here the extent of brain volume loss and ventricular megaly, which is quite global, even in the context of not whole brain radiation, but focal brain radiation. And this patient also, similar to the first case, had significant deficits on neuropsychological evaluation, namely with executive function and memory deficits. And lastly, a third case of a somewhat younger patient in her 50s, 57 years old, who 14 years prior was treated with radiation, so not chemotherapy, also for a low-grade glioma, an astrocytoma of the temporal region. And you see as well here the extent of brain volume loss that has occurred over the course of just 14 years, and similar findings on neuropsychological assessment involving also language dysfunction, processing speed abnormalities, as well as executive dysfunction and memory alterations. So coming back to the issue of white matter injury that was so elegantly outlined by Dr. Monge's talk and the underlying mechanisms, this here gives you a flavor of potential injury to white matter tracts that are quite global in the context of chemotherapy alone, seen, for instance, after intravenous methotrexate for lymphoma, a classic feature that is almost not sparing any patient. It's really a matter of the degree of injury, but also seen in drugs like ARC, another anti-metabolite commonly used in patients with leukemia and lymphoma, or in the setting of bone marrow transplant. If you look at this image, you appreciate that there is, from a pure clinical perspective, almost no difference in the extent and the pattern of injury in the cortical, subcortical, white matter, confluent signal abnormality associated with brain volume loss. This is a somewhat tragic scenario of a patient in their 70s treated prophylactically with whole brain radiation for an underlying carcinoid tumor of the lung that has a high propensity to involve the brain. But within just a few years, she developed various issues of neurological injury, including gait difficulties, dementia, and incontinence. So brain atrophy is obviously now an important feature that you have seen in some of these examples. And we looked at this in a more prospective fashion in patients treated with standard chemoradiation following the protocol outlined by Stoop and colleagues that Dr. Klein had earlier highlighted. And what you see in this study that is done to really monitor by frequent brain imaging, standard clinical brain imaging over time, the rapid onset of brain volume loss that occurs in these patients. Changes are evident within just a few weeks, and then accumulate to a point where you have approximately an expansion of ventricular volume by more than 40% within just 6 months after treatment. Notably, when analyzing the impact on gray matter and white matter as it contributes to the global brain volume loss, then gray matter was really more evident on early analysis to drop in its overall volume in these patients studied prospectively, and white matter seemed to be initially at least preserved. However, long-term studies, and here by looking at a cohort of patients that were also treated with an anti-VEGF target, cediranib, identified that gray matter and white matter really are suffering over time and have ongoing decline years after initial treatment. You may wonder whether radiation is the driving force, and so we looked at a patient population that was not even exposed to cranial radiation, which is systemic lymphoma patients, and identified that even after high-dose chemotherapy regimens in the context of bone marrow transplant, that patients do have evidence of brain volume loss and atrophy, in particular notable in large white matter tracts as the corpus callosum, as you can see here, which had a significant decline by DTI imaging. An aspect that I would like to highlight, which has perhaps not been mentioned to this degree, is the impact on vasculature. And vasculature is relevant for maintenance of plasticity. The whole field of neurogenesis and gliogenesis has really centered also around the proximity of early neurogenesis to cluster around capillary systems. So the neurovascular niche is critically important for maintaining brain plasticity. And so we conducted a study a few years back on patients that were treated with craniospinal radiation and its impact on vessel integrity, and in particular on the evolution of microbleeds that are notable in long-term survivors. And so medulloblastoma patients is one of these examples of a disease of a patient that can be cured with a high cure rate, and patients will live hopefully decades, but have many times delayed complications of prior treatment. And so what was becoming evident was the fact that the evolution of microbleeds is steady and progressive even long after the treatment has ended. It takes on an almost exponential curve if you look long enough, and none of the patients is spared after craniospinal radiation from developing microbleeds. And the question is really how severe it is, and whether patients develop more complications from that, such as the evolution of cavernomas and more larger bleeds that, if in eloquent areas, could lead to substantial neurological dysfunction. Another feature out of this was, which is relevant for clinical practice, is that patients who are treated with antithrombotic treatment or even anticoagulation for unrelated reasons, such as atrial fibrillation or stroke syndromes, have a much higher risk of developing progressive microbleeds than patients who were not treated with antithrombotic mechanisms and medications. This here is an example of a young gentleman I helped to treat. He was in his 20s when diagnosed with a medulloblastoma, had craniospinal radiation, and you see the evolution over just 5 years in the lower panel of the degree of microbleeds that evolve, in particular in posterior parietal regions, and including cavernoma evolution, and also the degree of brain volume loss that occurs almost in parallel. Whether there's a direct link between vascular injury and brain volume loss remains to be shown, but at least basic science data points to that direction. We also looked at patients in the population of low-grade glioma and found quite similar features. So these are patients that are not treated with whole brain radiation or craniospinal radiation, but have focal radiation to the area of tumor, and also see an evolution that follows a similar pattern, which is slowly progressive over time, even in the absence of treatment. And lastly, so you see here an example of a success story, but on the other hand, of a sad outcome. This is a patient with an IDH mutant glioblastoma, a young guy, was 31 when he was diagnosed in 2003, had a lesion, as you can see in the upper panel in the left parietal brain, that was successfully removed, but years later developed worsening symptoms. He had evolution of significant necrosis to the area, microbleeds, large hemorrhages, and was from that majorly impaired, both in terms of vision, mobility, motor dysfunction, essentially became wheelchair bound. He had 3 surgeries in order to identify the changes, because the chance was very high that he would have recurrent disease, which he was never shown to have, but what he did have was progressive injury in terms of coagulation, necrosis, and hemorrhages into the area. He eventually passed away from his complications. So it was a, as I said, success story in terms of tumor control, but given his long survival in the context of heavy treatment to the brain, was really characterized by numerous complications. I did mention the issue of tissue necrosis after cancer therapy. So this is something that we are all familiar with, especially when it comes to tumor board discussions. When patients are seen with new areas of enhancement, and the question comes up, is this something that is worrisome in terms of tumor progression, failure to treatment, or is it actually a feature of delayed complications from prior treatment? We do label it classically as radiation necrosis, but while there is a high association with radiation, it's not uniformly demonstrated that this could not also occur because of the combination of other treatments, so that act in concert, such as temozolomide and radiation. This is an example of a 35-year-old with a low-grade tumor, again along those lines of low-grade tumor patients treated aggressively who live substantially longer, and he had biopsy-proven radiation necrosis in the areas that you see here that eventually became bifrontal. He had progressive decline, was treated with high-dose steroids, could not get substantial improvement in his symptoms even with the anti-angiogenic agent bevacizumab, and eventually had a fatal outcome from these delayed and progressive complications. So these are not trivial delayed side effects, and we put together a series and really looked at patients who had biopsy-proven tissue necrosis, what the pattern is, and we always talk about radiation injury that can be from its temporal pattern, acute, early delayed, or delayed, and the issue of pseudoprogression, which is one form of necrosis, can occur, but somewhat earlier, typically within the first 6 months, and is a very common feature in approximately 40% of patients treated for glioblastoma with standard chemoradiation, but is really the major challenging point for patients that develop necrosis and tissue injury years later. The longest one we've had in our series and in our clinical practice was 21 years after initial treatment, who developed radiation necrosis or treatment-related necrosis that was biopsy proven and not to be tumor. Metabolic changes is another phenomenon that we have studied years back in a group of patients that did not even have any brain injury. They were not treated for brain tumors. They were treated for lung cancer with chemotherapy. And we picked this cohort because platinum are drugs that can have impact on the vasculature, have impact on endogenous antioxidant levels for decades later. This is well studied and known. And so we identified that systemic chemotherapy here with platinum compounds decreases brain metabolism in a significant manner, which has been puzzling to our nuclear medicine folks, because the brain has traditionally served as one of the reference organs for radiotracer uptake. And to see that systemic chemotherapy with platinum compounds can alter the metabolism in the brain was a somewhat shocking experience, whereas the liver had been quite stable in its uptake and metabolism over time, regardless of treatment or not, but the brain wasn't. And that raises yet another level of complexity of whether injury that is manifesting as metabolic changes in the brain could contribute to some of the long-term outcomes and deficits that are encountered in these patients. So to summarize some of the clinical features that you have just heard about, and I try to summarize and mirroring somewhat the important findings from Dr. Monge's talk in terms of the importance of myelin integrity for brain plasticity, and also the interaction and communication between various cellular phenotypes and populations such as astrocytes, microglia, and oligodendrocytes. You see here this hierarchical injury model that can often start with chronic inflammation or direct cellular toxicity from some of the drugs or radiation on various cellular populations, oxidative stress that has been often mentioned to occur with reactive oxygen species, and in direct or indirect pattern leading to issues of microglial activation or alterations and mitochondrial damage, and as a consequence of this, to a much more higher complexity, deficits in myelin, neurovascular injury, and eventually a picture of neurodegeneration that is unprecedented in some of the long-term survivors. But going back to the clinical practice, when you have a patient that shows up on your doorsteps and you have to evaluate a patient, it is not just as simple as perhaps outlined in our thoughts and hypotheses or model systems. It is very complex, as you know, and Dr. Klein and Dr. Weffel had alluded to this. Genetic factors play a role, endocrine issues, gender, female or male, then sleep, fatigue. Many of the mood complex disorders will have an impact on overall cognitive function, and obviously the cancer itself and treatment modalities. So clinical practice is complex and not always straightforward in terms of where to start and what the main culprits are. And I think one of the biggest issues that stands in the room and is unanswered is really the main question: who is at highest risk, and how can we predict and perhaps intervene earlier to prevent delayed injury? So to summarize briefly, one of the key clinical features that I encountered in practice is not only the cognitive impairment, which is central to this symposium today, but also the aspects of mood, alteration, fatigue, seizures that have an impact on all of the above, chronic sleep disorders, and then also the vascular complications such as stroke, endocrine issues that are permanent and need to be corrected, and also secondary tumors, which I have not highlighted here, but are also a clinical important feature that is relevant for long-term survivors. And on imaging, lastly, the issues of white matter injury, tissue necrosis that can be quite delayed, brain volume loss that might drive aging phenotypes and perhaps accelerate aging, and then issues of hydrocephalus, ventriculomegaly that could impair autonomic dysfunction, lead to incontinence and gait instability, and then the complex of microglials and neurovascular damage. So with that, I want to emphasize that, and this is obviously preaching to the choir at UCSF, who has been an example of building a center that has focused on the management and survivorship and complexity of issues that arise in these patients. You need a large team to go hand in hand to really address many of the aspects that are relevant in long-term survivors and even in patients that are actively treated. This is not something that can be achieved by one discipline alone, and really requires insights and expertise from many experts, as illustrated in this summary slide. So I want to not finish my talk without acknowledging many of my collaborators and friends over the years, including Michelle and Jeff across the country and the globe. So these are efforts, I think, that cannot be done alone by a small group. You need collaborators to really thrive and and make inroads into the pathophysiology and mechanisms of what we are talking here today. So with that, I would like to thank the audience for your attention, and again, the organizers for having me to join this symposium today.
Thank you so much, Jörg. That was great to wrap up our morning session with a clinical perspective. I was wondering if you could comment a bit on how seeing what you've seen now in the years you've been a neuro-oncologist, how this has changed your practice in talking with patients, particularly patients with lower grade tumors, regarding options for treatment, kind of in a sort of real life scenario.
Yeah, I think looking back perhaps 10, 15 years, one thing I can say with certainty is that in the early stages, this topic really was neglected in discussions in clinical practice. Everything centered really around cure, which still does, but I think the aspects of quality of life and when perhaps to withhold a certain treatment modality and when to alert a patient of issues that might come up, much more now, I think, in the mind of any practitioner who sees these patients, and these are discussed in terms of long-term side effects that are possible. So I think that is a positive phenomenon and evolution in this field. For patients also to be aware of issues like this, everybody uses the internet and is aware of potential side effects of treatment. So I think what is really changing is that this is not only part of a lot of prospective clinical investigations and studies, but also is really part of the everyday discussion when it comes to choosing a particular treatment for a patient. Where we are really not yet is the fact that who is at highest risk and when perhaps to say this particular patient will with certainty develop major deficits in 1 or 2 years and maybe we should hold back. I think one area where we have learned to do this is perhaps in glioblastoma with some of the studies that have shown in elderly to perhaps hold radiation and treat them with temozolomide if they have MGMT promoter methylation in their glioblastoma, to just buy them a few more months of better quality of life. But I think these are topics that I believe we will hear more and more frequently in the future.
Thank you. A couple questions from the audience regarding multidisciplinary approaches that you've incorporated into your clinic, specifically around speech therapy. And I know you have a wonderful neuropsychologist that you work with as well. So I'm wondering how that's been integrated into your practice on a day-by-day basis.
Yeah, so one important feature is that all disciplines participate in our tumor board conferences. And we have a very low threshold to involve speech and neuropsychology in the assessment of our brain tumor patients, even prior to treatment. So a classic scenario is a young individual comes with an eloquent area that is affected by the tumor. So we would usually prospectively analyze this patient and do a baseline neurocognitive assessment, and then really instruct and follow this patient along as the treatment is administered and see how they do. And that goes hand in hand with our colleagues from palliative care who manage symptoms and really have a close eye on aspects that could interfere with overall outcome. So I think it's an open discussion, and that is something that we embrace and have actively incorporated in our clinic. The clinic itself obviously is a referral base for other patients who come with cognitive issues, who have been treated for breast cancer, for lung cancer, for colon cancer, may not even have any issues in the brain, but this comes up, or after stem cell transplant, and that's a large population of patients we do see in our clinic. So I think it's evolving, but I'm at least happy and fortunate to be at a place where this is actively incorporated in clinical practice.
And then maybe one last question from the audience. So are you seeing differences in the distribution and extent of vascular injury, microbleeds in patients with protons versus photons, given your access to proton radiation at Mass General?
Yeah, that's a fantastic question, Jenny. So I think This is actually a study that we are performing right now, side by side, comparing photon versus proton radiation, not only in high-grade, but also in low-grade glioma patients, and to assess their impact on microvascular integrity and myelin function and cognitive function over time. Preliminary results suggest that the localized impact is quite similar, but that perhaps with proton radiation, the distant onset of micro is less prevalent. But what we don't know is whether this has functional consequences. I think seeing this over years to come will be of importance to perhaps offer some individuals that are at higher risk the modality that is less likely to cause like side effects or neural injury, but this remains to be shown.